Welcome. Today we'll talk about integrating oral SERDs and combinations into the ER positive, HER2 negative metastatic breast cancer treatment arsenal and really review practical guidance for multifactorial clinical decisions. Now, remember, this is a part three of a three-part series of virtual workshops, which is titled Changing the Scenery in ER positive, HER2 negative metastatic breast cancer with New Oral SERDs and Combinations, Foundations, Evidence, and Practicalities. I'm Komal Jhaveri, a breast medical oncologist at Memorial Sloan Kettering Cancer Center in New York. And joining today is a dear friend and colleague, Professor Joyce O'Shaughnessy, who's the Celebrating Women Chair in Breast Cancer Research at Baylor University Medical Center in Texas. Welcome, Joyce.
Thanks, Komal. Good to be here with you.
And thank you to all of you participating in our workshop today. I'd also like to thank PeerView and MetaViver for providing this educational session, and for Lily for providing the educational grant for this session. Please engage with us today and look out for the polling questions during the workshop, and certainly submit your questions to us in the chat window, and we'll answer them throughout the workshop. I'd also like to take a moment to thank our partners, which is a patient advocacy partner for this program, MetaViver. Now, MetaViver really is an organization that is focused exclusively on stage 4 metastatic breast cancer with a mission to improve the lives of people living with advanced breast cancer by funding research, advancing policies through advocacy, and facilitating a community of peer-to-peer support. We are very grateful for MetaViver for contributing insights from patients and their care partners as part of this program. Please also access and use the supplemental resource compendium that is made available by MetaViver as a component of this program. You can certainly view the slides and the practice aids now and download them after the event as well. If you need any additional information, feel free to send an email to live@peerview.com and certainly join the conversation on X @peerview. The two goals for today's discussion are first, to equip us with skills in developing individualized treatment plans for patients with ER positive, HER2 negative metastatic breast cancer, incorporating oral SERDs and combinations. And second, to provide us with strategies for engaging patients in shared decisions about treatment selection, as well as improving the adverse event management and adherence when utilizing oral therapies. So let's kick off by putting data to practice in a step-by-step fashion and talk about the practical strategies for integrating oral SERDs and combinations into treatment plans for patients with ER positive, HER2 negative metastatic breast cancer. Now, here's what has been happening to date. We've had a rapid advancement in terms of having novel endocrine agents being available, either as approved agents or as newer data that has since been reported, which will hopefully soon change our treatment landscape. Essentially, we've had oral SERD monotherapy trials where we've seen a consistent benefit in patients with ESR1 mutations, but we have also recognized that 40% across the board in these trials still develop early progression on monotherapy, and 60% still will have only a less than 6-month benefit, really highlighting the unmet need for combination therapies. Talking about combinations, we had data that was presented and published from the EMBER-3 phase 3 trial, where not only did we see monotherapy, again, activity in ESR1 mutant tumors, but we also saw data for the combination of imlunestrant and abemaciclib, which was better in terms of improving progression-free survival compared to imlunestrant alone. And this was seen regardless of ESR1 mutations and even despite prior CDK4/6 inhibitor progression. More recently at the ASCO annual meeting, we saw data, which is also published now, from the phase 3 SERENA-6 trial, a very interesting trial, very important trial, where we were trying to focus on really targeting emerging ESR1 mutations. So really make an intervention with molecular progression without radiological progression. And we saw that when we switched the AI CDK to camizestrant and continued the same CDK during first-line therapy, there was an improvement in PFS compared to when we continued the same AI CDK combination with emerging ESR1 mutations. And not only have we seen monotherapy data with oral SERDs, but we've also now seen that with a PROTAC, a proteolysis targeting chimera, in the phase 3 VERITAC-2 trial, where we showed superiority for vepdegestrant compared to fulvestrant in patients with ESR1 mutant who had prior treatment with a CDK4/6 inhibitor therapy. Many other trials are still underway, including combination trials in the first-line endocrine therapy setting, and several other combinations, including with everolimus, that are currently ongoing. So maybe I'll pause here for a second, Joyce, and see what do you think about these data, and where might these new therapies fit within our existing treatment algorithm?
Very exciting times. These are like paradigm changing, some of these trials. The whole Serena 6 raises the question of, should we try to detect molecular progression in the first line setting prior to the detection of clinical progression? Will that ultimately improve survival or substantially improve quality of life? So fascinating. It is great with EMBER-3 to have a combination of an oral SERD with another targeted therapy. In this particular case, abemaciclib, a CDK4/6 inhibitor. We need combinations. And it's great to see more single agent oral SERDs, but also the vepdegestrant, that brand new mechanism of action. Very, very exciting. And we'll look at some algorithms and see where these might fit in as we go along.
Yeah, thank you. So before we get into the algorithm, why don't we talk about this case? So we have a 59-year-old postmenopausal woman with ER-positive, HER2-negative metastatic breast cancer. Now, she was really diagnosed with de novo metastatic disease with numerous liver and bone metastases that included spine, hip, and ribs. Very appropriately, she received first-line CDK4/6 inhibitor therapy, in this case ribociclib, with an aromatase inhibitors. But unfortunately, 18 months into this therapy, developed asymptomatic progression in bone and also new liver lesions. ctDNA testing was performed at the time that revealed presence of ESR1 mutations and no alterations in the PIK3CA, AKT, or PTEN. There was no evidence of germline BRCA1 or 2 mutations as well. So why don't I have our audience answer this polling question? Now let's assume that all below options listed on the slide are clinically available. Which second-line therapy would be your preferred option for this patient? Your choices include abemaciclib with fulvestrant, everolimus with fulvestrant, abema with imlunestrant, continue ribo, switch the endocrine therapy to camizestrant, elacestrant monotherapy, imlunestrant monotherapy, vepdegestrant monotherapy, something else, or I'm not sure. So take a moment and answer this poll, please. Thank you. And maybe, Joyce, why don't you tell us, how do you think about these treatment options and where do you think they fit in our treatment algorithm?
Absolutely. Metastatic breast cancer has become more complex because we do need to do NGS genomic evaluation of the cancer at various steps along the therapeutic continuum because of the emergence of new mutations. And so with this particular patient, she was de novo metastatic. So in the red box, the upper half of the slide, very nice algorithm here, where she receives, as you see, first line treatment. She received the AI plus CDK4/6 inhibitor. She benefited. She had 18 months. Now we need to think about second line treatment, right? So now we need to understand her genomics. And in the blue box, wild type, nothing is found. Circulating tumor DNA, a plus minus a biopsy of the liver metastasis and NGS. Next choice, an ESR1 mutation, which in her case is exactly what was found. And then lastly, she could have had a PIK3CA, AKT, mutation, either in isolation or co-mutant, for example, with an ESR1 mutation. So in this particular woman's case, she has an ESR1 mutation. We certainly want to utilize an oral SERD or once approved the PROTAC vepdegestrant. And we will have, once we have FDA approval, 3 options for monotherapy: elacestrant, imlunestrant, the oral SERD, or the vepdegestrant, the PROTAC. we will also have the combination of the imlunestrant plus abemaciclib based on the EMBER-3 data. This is a discussion with the patient. I think because she had bone and liver at presentation and because she had only 18 months of progression-free survival, I would lean towards the combination. In her case, with the imlunestrant to go after that ESR1 mutation and then switch her CDK4/6 inhibitor from ribociclib to abemaciclib. So that would be my choice in her particular case. But we do have the opportunity to talk about monotherapy with her as well.
Right. Fantastic. And thank you so much. In fact, that is exactly what I was hoping that we could talk about. That how do we make this decision? It's an embarrassment of the richest, isn't it? We're going to have more than one option that is applicable, which is a good problem to have, but also a tricky one sometimes, because then we have to figure out what's the right choice and is there a right choice and how do we come up with a decision for a right choice for a given patient. So broadly, if you were to think about monotherapy and combination, assuming both of them available to you, is there a particular recipe for you to then figure out that combination is the way to go for this particular patient versus monotherapy? How do you think about that? If you could talk to us about that.
Well, assuming she's got the ESR1 mutation and she had more than a year of benefit from the CDK4/6 inhibitor, she could be, if she had, for example, small volume bone only disease, relatively asymptomatic, you could consider an oral SERD monotherapy, such as elacestrant, soon to come, the vepdegestrant, which of course is a oral Protac, or the imlunestrant. I think for patients with heavier tumor burden, particularly liver metastasis, and she got 18 months, for de novo metastatic, the median would be 2 years. She got a little bit less than that. I'd be leaning towards the combination therapy for her. So it would basically be based on overall tumor burden and biology of the disease, really defined by how long her prior treatment was, symptoms, overall tumor burden, and organ function, et cetera. But in this case, since we hope to have that combination of imlunestrant and abema in hand, in soon, that would be my option, my choice for her.
Fantastic. Thank you so much. That totally makes sense. So thanks for walking us through that logic in this particular case, at least. And, traditionally, when we think about no biomarkers, we always, reached out for everolimus in such conditions, right? We would think about, can we use a combination with everolimus when there is no biomarker? We also heard about EMBER-3 and how EMBER-3, the combination, potentially is active even regardless of an ESR1 or a PI3K mutation. So again, we might have more than one choice. How do you think about that? And how do you, put that into context if the ctDNA testing in this particular patient did not yield any biomarker? How would you think about those data and what would you choose?
Right. And, I have not been a big fan personally of everolimus post-progression on CDK4/6 inhibitor for patients with liver metastasis. Bone, great. I have not had good success with liver metastasis, so that wouldn't be something I would lean towards. Single agent fulvestrant is really quite ineffective post-progression on CDK4/6 inhibitor therapy. We did see data from the post-MONARCH trial combining fulvestrant with abemaciclib. That could be an option for this patient. But an all oral combination of imlunestrant and abemaciclib would probably be my choice, again, just for the convenience. In ESR1 wild type patients, the oral SERDs are identical in effectiveness to fulvestrant. It's not that they don't work, they're just identical. And so the imlunestrant and the fulvestrant, they're the same in the EMBER-3. It's the same efficacy. So the combination of the imlunestrant plus the abemaciclib in EMBER-3 in the ESR1 wild type population was substantially more effective than single agent imlunestrant, not surprisingly. So that's what's nice about that combination. It'll be available to us both for ESR1 mutant as well as ESR1 wild type population, giving us an all oral option for patients.
Yeah, fantastic. Again, thank you again for walking us through. I think it's so true that, while everolimus is an option, if you look at the most recent single arms friend study that provided some data for fulvestrant with everolimus post CDK, again, 57 patients, very small study, it was still 6.8 months. And I think with EMBER-3, which is a larger phase 3 trial, a randomized trial, we did see that post CDK, the combination of imlunestrant plus abemaciclib was 9.1 months. And so it does seem like this all oral option is one advantage. Of course, to have for our patients. And it seems like the PFS benefit that we've seen, again, we can't do cross-trial comparisons for efficacy, but at least when we think about data that we have, 9 months seems to be more appealing for a patient population. So do agree with your thought process there. What about if the tumor also had a concurrent PI3K mutation or did not have ESR1 and had only a PI3K mutation? How would you think about that particular scenario?
So if they only had a PI3 kinase mutation, again, we will have options. We could certainly consider the fulvestrant capivasertib combination, which has been heretofore my go-to. Again, I'm intrigued in the EMBER-3 trial, specifically looking at patients with the PIK3CA, AKT, PTEN, mutations. The combination of the imlunestrant and abemaciclib, again, was significantly superior to imlunestrant alone. And again, in a ESR1 wild type, we would think of the effectiveness of imlunestrant very similarly to fulvestrant alone. So that combination of going after that estrogen receptor, regardless of ESR1 mutation status, plus abemaciclib, was effective regardless of the molecular subtype that we know to look for, and regardless of prior CDK4/6 inhibitor therapy. So that would be very appealing to me. So I would be between fulvestrant and capivasertib or imlunestrant and abemaciclib. If the patient was co-mutant with ESR1 and a PIK3CA, AKT, or PTEN, there we would really need to go with the imlunestrant abemaciclib, because that's the only combination data we have that will be available to us once FDA approved to go after the mutant ESR1 with imlunestrant, and then the abemaciclib is effective regardless of wild type or alterations in the PI3 kinase pathway.
Thank you. I think that very, very helpful to understand this perspective and this logic behind how you would approach that scenario. And does the use of a specific CDK4/6 inhibitor in the first line setting matter when you think about these data sets that are available in the second line?
No, in the EMBER-3 trial, patients, 60% had a prior CDK4/6 inhibitor. And that's where we actually saw a very nice improvement. It was 9.4 months. Is that right? It was 9.4 months? No, it was 9.1 months in the prior CDK4/6 inhibitor patients with the combination. And they had the prior palbociclib or ribociclib, and then came in with the imlunestrant and abemaciclib afterwards. So we have very good data on that. And then also in the post-MONARCH trial, 100% of the patients had prior CDK4/6 inhibitor, and then the combination of fulvestrant and abemaciclib was superior to fulvestrant alone. So, no, I think that most patients will be getting, more often than not, ribociclib in the first line setting, although there's certainly room to use any of the CDK4/6 inhibitors first line. But if they did get palbo or ribo first line, there's very good evidence now for utilizing the abemaciclib in the second line setting.
Thank you. Yeah, no, I agree with that. I feel equally convinced that I think regardless of palbociclib or ribociclib, which is predominantly what patients would be getting, some patients could be getting abemaciclib. That's a different scenario, but that's a fewer group of patients, I feel like, at least from what we've understood, and certainly good data across data sets for abemaciclib in the second line. So I think this was a great discussion. Before we move on, why don't we have another polling question that you can answer for us? So please answer this polling question indicating your preferred treatment recommendation now based on what you have learned so far with this discussion. So take a moment and answer this poll, please. Now let's move on with the second case. We now have a 62-year-old postmenopausal woman with ER-positive, HER2-negative metastatic breast cancer. She had received prior adjuvant endocrine therapy, but developed recurrence within 12 months of completion of adjuvant and AI therapy, and currently has extensive visceral metastases. ctDNA testing revealed neither the ESR1 nor the PIK3CA AKT PTEN alterations, and no germline BRCA1 or 2 mutations were detected as well. Again, assuming all options are available, which therapy would be your preferred next option for this patient who's recurred within 12 months of adjuvant AI and no alterations? Would it be fulvestrant CDK4/6 inhibitor combination, fulvestrant palbo inavolisib, abemaciclib imlunestrant, imlunestrant monotherapy, something else, or I'm not sure? Take a moment, answer this poll, please. Thank you. So maybe, Joyce, you can walk us through the treatment algorithm for such a scenario.
Absolutely. So she has had her AI and she's recurred within a year of stopping it. And she recurred very aggressively with diffuse visceral metastasis. She really has endocrine therapy resistant disease. So I would not be interested in single agent therapy for her. And we do want to evaluate her at that point for PI3 kinase mutation, because down the bottom of our slide there, where it says PIK3CA mutation, she's recurring within a year of stopping her adjuvant endocrine therapy. She's a candidate for fulvestrant and inavolisib and palbociclib. Very, very important to know that. Now, in this particular case, she does not have any alterations. And so she needs a CDK4/6 inhibitor. She's not had one. So we actually have two best choices for her, in my opinion, up at the top there: the fulvestrant CDK4/6 inhibitor or the imlunestrant plus abemaciclib. I'm very comfortable with both of those options. You can see the other option in blue there, imlunestrant, but that is for an ESR1 mutant cancer, or elacestrant could be another option for an ESR1 mutant cancer. But I think that's where we are right now in the first line treatment for this patient. She's been appropriately looked at molecularly and without any alteration. I think we've got to give her a CDK4/6, no question. And she needs a ER targeted agent, either fulvestrant or the imlunestrant.
Fantastic. So maybe let's think about this case a little bit more and think about scenarios that we might face, right? So, which disease, tumor, treatment, and patient factors or characteristics would be considered in the clinical decision making among these patients? I think you walked us through some of this, that it's recurrence within 12 months of endocrine therapy, and if it was ESR1 mutation, you could consider monotherapy. But if you, as you pointed out, if you have the ESR1 mutation and the patient has not had a CDK, is there a preference in the first line you would have in such a scenario?
Yes, she really does have to have a CDK4/6 inhibitor. And even with an ESR1 mutation, elacestrant was evaluated after a CDK4/6 inhibitor. So she really needs that. If she's wild type on ER, as this patient is, then either fulvestrant and a CDK4/6 inhibitor. I will tell you that for an aggressive visceral recurrence, my preference would be abemaciclib for the patient. If she's got an ESR1 mutation, then imlunestrant is the choice. It's our only established combination therapy, is the imlunestrant plus the abemaciclib. Now, it turned out in EMBER-3 that regardless of mutation status, patients benefited, significantly more from the combination of adding abemaciclib to imlunestrant compared to imlunestrant. So, if she had a strong preference for an all oral regimen in the absence of an ESR1 mutation, then she's also a candidate for the imlunestrant plus abemaciclib. So, but those are the kind of the two choices I would come down to.
Yeah, that makes sense. As you pointed out, EMBER-3 allowed both first line and second line patient population as long as they had recurrence on or within 12 months of either their adjuvant endocrine therapy or progression, on their first line metastatic AI-based therapy. So this patient could be a very appropriate candidate for that therapy or a fulvestrant CDK, as we have been treating before these data. And I think we touched upon with the ESR1 mutation, how we would think about this. What if there was a PIK3CA AKT-P10 alteration present? How would you approach this case from that perspective?
So if she has a PIK3CA mutation and she then fits the INAVO 120 eligibility criteria, so if her hemoglobin A1C is less than 6%, I think the best treatment for her would be inavolisib, fulvestrant, and palbociclib, as in the INAVO 120. If she had an AKT-P10 mutation, however, she still needs a CDK4/6 inhibitor. I would not prioritize capivasertib, for example. So she's never had a CDK4/6 inhibitor. She needs one. And so it's really, again, if she needs one, my preference would be abemaciclib because she's got very aggressive disease, and it's either going to be with fulvestrant or imlunestrant. Imlunestrant, either ESR1 mutant or wild type, fulvestrant only ESR1 wild type. And so all oral regimen, I think, will end up being very desirable, be very appealing to women, I think.
And if you had both ESR1 and PIK3CA in this first line setting, do you think the INAVO 120 regimen would still be appropriate?
Not probably not my ideal, to be honest with you. One could potentially argue that, and I don't know that we've seen the data yet, Komal, from from the INAVO120 for those with the PIK3CA who also were co-altered with the ESR1. So that could be an option. But I'll tell you, if we've got those two targets right there that no doubt are very, very important in this rapid recurrence in this visceral disease, I would like to go after that mutant ESR1 with one of our oral SERDs. And then, of course, in combination, she's got to have a CDK4/6 inhibitor. So I probably would prefer the imlunestrant abemaciclib combination in the context of having the dual mutations, although I think one could make the argument for the INAVO120 regimen as well.
Wow. Yeah, no, I think absolutely appropriate. And thanks for walking us through. You're absolutely right. We still await data for other alterations from the INAVO120, specifically looking at what would be the scenario if there was an ESR1 mutation also present. And certainly the EMBER-3 did provide us with that data, but it's clearly a data-free zone. We really don't know what the right approach would be. I think it's very appropriate to think about the triplet first, and then maybe an imlunestrant abema-like regimen in the second line setting if it was still appropriate, or in a certain scenario, if we wanted to go with the doublet first and keep, capivasertib or something like that at the back end, if it was an AKT or a PTEN alteration, that would be appropriate as well. So I do think we need to await a little bit more from subgroup analyses from these larger data sets to be able to understand this better. Hopefully, when Capitello 292 reads out, which looked at, capivasertib plus CDK4/6, including ribo and palbo, and fulvestrant in this setting, maybe for AKT alterations, we could have that as an option. And hopefully one day we'll have a novel endocrine agent and a triplet as well. So our future is still going to depend on all those newer readouts that might come out eventually. Again, before we move on, why don't we address this polling question, indicating your preference as a treatment recommendation now that you have heard our discussion about this case and all the data around it. So please take a moment to answer this poll. Now, moving on to then improving adverse event management, talking about adherence and persistence with oral therapies. What do we know about patient burden and preferences related to oral versus other routes of delivery for breast cancer therapies in ER-positive, HER2-negative metastatic breast cancer? And maybe you can talk to us a little bit about patient perspectives and preferences, Joyce.
Absolutely. I think patients are generally open to whatever the most effective therapy is for their breast cancer, and particularly their metastatic breast cancer. But of course, there's actually a lot of evidence that oncology patients prefer oral regimens to a systemically administered IM or IV therapy. I think more than anything else, it's convenience. It's the ability to receive care at home and keep less time in the office and more time dedicated to their other obligations in life. Of course, IM or IV injections can be uncomfortable, and they just have a greater sense of control. And, I think we all understand this very well, that this is a big deal. Some driving into the cancer center on a regular basis is very, very difficult. It's very inconvenient. It's very time consuming. And it's a real hardship for a lot of patients. I think that's more than anything. And just the idea of staying away from the cancer center and having that less anxiety and that more sense of health because you're staying away from the cancer center. So I think oral therapies are very, very definitely preferred, if they're equally effective or even more effective.
And how do these oral SERDs compare in terms of their adverse event profiles? And are there considerations for management of the specific adverse events when using these therapies, either alone or in combinations? And really, what guidance would you offer based on your experiences to maximize adherence and persistence to these oral therapies, which really is very, very important, especially as we start utilizing these agents in the first-line metastatic setting for a long period of time, and more importantly, in the early adjuvant setting where they're being interrogated currently in phase 3 trials.
Well, the great news is they're extremely well tolerated. So this is fabulous. We're familiar with elacestrant there on the top left, and you can see that the red is pointing up there towards nausea, which is really the main toxicity. Really, I think of it as the only toxicity of elacestrant. It goes away over time and really can be mitigated by taking the medication with food. Camizestrant over on the right, another one of our oral SERDs at higher doses, you can see some photopsia and you can see some bradycardia, but at lower doses, it's very, very little, of that imlunestrant in the bottom center there. There's some fatigue, there's some nausea, and there's a little bit of diarrhea. Again, nausea. These are very transient and again can be mitigated with taking it with food. Fatigue as well. Usually tachyphylaxis and goes away, and diarrhea is really quite minimal. Again, these GI issues tend to go away pretty rapidly. And giredestrant at higher doses, you might see some bradycardia, but at the lower doses, really not. And amcinestrant is no longer in development. So these are overall very, very well tolerated. One of the key things we want to do with our patients, of course, is really help them adhere and persist with therapy. Now, in the metastatic setting, that's really less of an issue as long as patients can get access to the medication. Then we have a whole, group of patients in our cancer centers, a group of people in our cancer centers that are helping patients with access and with co-payments, et cetera. But most patients understand the necessity, fully understand it. We're being very proactive, helping them with adverse events. And we are really managing comorbidities as well and helping them access other specialists and their primary doctors in the healthcare system so that they can get the help they need. And again, trying to help them with the issues around convenience and travel and cost. And so what can we do in particular? We can try to keep the regimens as simple as we can, very, very good education, the motivation, what's the upside of taking this, also what to watch out for, toxicity wise, when to call us. And basically it's education. I also find that seeing the patient fairly regularly when we first start a new therapy is very, very helpful. They really know that you're in there with them on it. You're really managing toxicities. And then we can start stretching out the visits once we know women are doing very well with the therapies.
Absolutely. I think our nurses, our frontline, teams that really interact with them, having them reach out to them or making them accessible, making ourselves accessible in those earlier time points when they just begin a new therapy is so critical and so key, just so that we can actually help them or maximize the support they need with any side effects, understand what they want to communicate, make any dose modifications if we had to, when we can, and when appropriate, so that they can stay on this therapy and derive the benefits. So thank you for providing these pointers. Now, from a patient perspective, I'd love for our audience to watch this video from one of our patients, really highlighting the importance of considering patient needs and preferences, including route of delivery of therapies, choices of oral versus intramuscular and intravenous therapies, and engaging in this shared decision-making process with their physicians. Among these patients, we want to see that with their care partners, and how does this play into their decision-making about what therapy they would like to start. So please see this video.
Hi, I'm Kelly Shanahan. I've been living with metastatic breast cancer for almost 12 years. I am the president and director of research of Mediviver, a nonprofit that raises money and funds metastatic-focused research. I'm thrilled to be with you today to give the patient perspective. Choice is a wonderful thing to have, and we have that now with endocrine therapy. We have oral medications, and we have injectable medications, and who knows, maybe in the future we'll have a transdermal patch. With the way that things are moving forward, who knows what we'll have. And I think it's really important for you as the clinician to talk to your patients about what is important to them and to ask them that question periodically, because it can change as their life changes and as they live longer with metastatic breast cancer. Some people may rather go see a doctor every month, may want to get an injection, may not want the side effects that can come with oral medications, where other people may live far away from your clinic and have to drive over an hour or 2 or 3 hours, and an oral medication that can be delivered to their home may be more convenient for them. And things may change. Someone may be happy on one medication for a long time, but circumstances change. So I think it's important as new drugs come available that you continue to let your patients know about what is available, about what the data shows, especially when there is progression. So they have the information that they need to make the decision that is best for them. Also, there's all these medications that are currently available now as monotherapy. Your patient may have been on a combination therapy before. There are trials with combination therapies. And I think, again, you have to keep yourself informed and keep your patients informed. And also, patients need to do a little bit of the work as well and keep informed about what their treatment options may be now and in the future.
And again, before we move on, why don't we have you answer a polling question on patient-centered care when using new and emerging oral therapies in ER-positive, HER2-negative metastatic breast cancer. So take a moment to answer this poll, please. So thank you so much, Joyce, for this lovely discussion. It was really, really fascinating to hear your insights, your suggestions, your thought process, your logic about all these therapies that we currently have. There's so much happened, there's so much happening, and so much more that is currently in the pike or in late phase that we will hear data from, which might further impact our treatment algorithms that you very nicely summarized for us today. Any final comments or thought processes you would like to share with our audience today?
I think it's really been fun, Kamal, to think through these new options coming our way. And I would just emphasize the importance of the ctDNA evaluation, the serial testing for ctDNA to look for ESR mutations and mutations in the PI3 kinase AKT PTEN pathway, because we do have a number of options. And I would just say it's great to be now moving towards targeted therapies in combination with the imlunestrant and the abemaciclib. That's our first oral SERD in combination, which we really look forward to being able to bring to patients, because we do want that longer progression-free survival we see with the combination therapy in general.
Thank you so much. And thank you all for joining in today for this very interesting workshop.